Good afternoon, everyone, and welcome to today's webinar, Connective Tissue Disorders and Ehlers-Danlos Syndrome. My name is Kim Roque, and I'm the Manager of Education for the Foundation for Women and Girls with Blood Disorders. Next slide. Our mission is to ensure that all women and girls with blood disorders are correctly diagnosed and optimally managed at every life stage. To that end, we aim to provide education to healthcare providers on the medical consequences and unique issues for women and girls with blood disorders. Next slide. I am joined today by our two faculty members. Dr. Pamela Trapane is a pediatric geneticist and is Professor in Chief, Division of Medical Genetics, Department of Pediatrics at the University of Florida College of Medicine in Jacksonville. Dr. Sarah O'Brien is a pediatric hematologist and associate professor of hematology and oncology and director of experimental therapeutics at Nationwide Children's Hospital in Columbus, Ohio. Next slide. Dr. O'Brien and Dr. Trapane have indicated that they have no relevant financial relationships to disclose. These are the learning objectives for today's webinar. In support of improving patient care, our webinar today has been planned and implemented by CineMed and the Foundation for Women and Girls with Blood Disorders. CineMed is jointly accredited by the Accreditation Council for Continuing Medical Education, the Accreditation Council for Pharmacy Education, and the American Nurses Credentialing Center to provide continuing education for the healthcare team. Next slide. The next few slides will provide information related to our accreditation process. Please note, next slide. Please note that you are also able to receive 1 hour of continuing medical education credits for participating in today's webinar at no cost. CME credits are available for physicians, nurses, nurse practitioners, and physician assistants. At the end of the webinar, we will provide additional information about receiving CMA credits, and we will email you that participated the links to receive credit. To ensure the best sound quality during today's webinar, all attendees will be muted and will be in listen-only mode. You will have the opportunity to participate in the question and answer session with the faculty at the end of the webinar. You may then submit your questions during or after the presentation portion of the webinar via the question box in your GoToWebinar control panel located on the right-hand side of your screen. And we will address those during the Q&A session at the end of today's presentation. For those who wish to refer to the slides later, we are recording the program and it will be archived on our website. The link to download the presentation may be found in the email you'll receive after the webinar's conclusion. Next slide. Before we begin, we have a question for the audience, a quick poll to see how many people are joining us today with others. Please take a moment to answer the question on your screen. Okay, we'll just wait for a few more people to vote. Please, if you haven't submitted your poll answer, please do so now. Okay. All right. Just a few more seconds. Thank you for your responses. Let's close the poll and move on to the next one. Now we have a series of 3 pre-test questions that we will give via poll. Please take a moment to answer the question on your screen before we move on to the next question. Note that for those of you who are sharing the screen with others, please just have one person vote. Since we do have so many of you who will be voting, we will wait just a few more seconds. Please do submit your response. Inherited connective tissue disorders commonly present with. Okay. Just a few more seconds. Okay. Okay, 2 more seconds. Terrific. Okay, and let's close the poll. Our next pretest question is about the Beighton score. The Beighton score measures. Okay. We're watching the numbers tick up. It's terrific. Go ahead and submit your vote if you haven't yet. Okay, we'll wait just a few more seconds. Go ahead and submit your vote. Okay. Terrific. Let's go ahead and close the poll. And our last question. EDS hypermobility type is? And select your response. Okay. If you haven't yet voted, please do click your answer now. You all are getting better at this. Thank you. Much faster. This is great. Okay. Terrific. And let's close our poll. Wonderful. And again, here are our learning objectives for today's presentation. Wonderful. And without any further ado, I would like to turn over the call now to Dr. Pamela Trapane. Dr. Trapane?
All right, so now I need to take control. Let's see if I can do this. All right. Oh, yay. Okay, so now I'm on. Hi, everybody. This is Dr. Pam Trapane. We're going to talk about Ehlers-Danlos Syndrome. In order to talk about that, we first need to review just a little bit about what is connective tissue. Those are individual cells that are scattered within an extracellular matrix. The most common of these cells are fibroblasts that secrete collagen and other elements of the extracellular matrix. But they also include our adipocytes, mast cells, macrophages, and lymphocytes. These cells then are extruding the extracellular matrix, and that contains both our ground substance and our fibers. The ground substance is ordinary connective tissue that is water that is stabilized by the glycosaminoglycans, proteoglycans, and glycoproteins, but also includes our bone that includes minerals and also our blood and the plasma of that component. Of our fibers, collagen is the principal fiber type, and it confers tensile strength with flexibility, and it is the most abundant protein in the body. Within those fibers also are elastic fibers that confer resiliency. So let's talk just a moment about our collagen. There are 28 types that have been identified, most of which is type 1. So 90% of our collagen is type 1 collagen. They are rope-like material that will intertwine with itself. So most of our connective tissue disorders are either defects in the collagen itself and how it can make these fibrils, or they can also be modifiers of that collagen. The most common 5 types of collagen include type 1, which helps us make our skin, tendons, our vasculature, organs, and bone. Type 2 is primarily in our cartilage. Type 3 forms our reticular fibers and is most commonly found alongside type 1. Type 4 is in the basal lamina. And type 5 goes to our cell surfaces, hair, and placenta. When you know some about the different types of inherited connective tissue disorders, it makes sense then which of the collagens is making that effect. Type 4 goes to some of our renal diseases because it's in the basal lamina of the kidneys. We can see problems with premature labor with our classic EDS patients because they have problems in collagen type 5. So it begins to make sense over time if you know which type of your collagen is actually affected. So connective tissue disorders then are multisystem disorders because they are manifest in all of our body systems. So we will see problems in our bones and joints, in the skin, eyes, vasculature, the nervous system, the GI tract, and both oral and dental issues. Because it affects all of these body systems, it becomes difficult then to diagnose in a clinical setting. Each of the subspecialists is only identifying or working on one part of the body, like the blind men and the elephant. So if you're just the orthopedist, you think people have loose joints and they hurt, you're only looking at that. They're not taking into consideration the easy bruising. Easy bruising may show up with hematology, but yet you didn't look at their joints. They may show up in GI clinic with chronic constipation. So when we are only looking at one organ system, it becomes very mysterious. And until we take the blindfold off and can see the elephant all for what it is, then it's difficult, but then it becomes very easy. So the Ehlers-Danlos syndromes in general are prototypes of the connective tissue disorders. They are a heterogeneous group that are characterized by joint hypermobility, skin extensibility, and tissue fragility. Overall frequency is about 1 in 26,000. Inheritance is primarily autosomal dominant, but the rarer types are autosomal recessive, and the mutations are in these number of collagen genes, and the rarer types that are autosomal recessive most often are in collagen modifiers, but there are a few that are actually in the collagen genes themselves. The three most common types of Ehlers-Danlos syndrome include hypermobility, EDS, the old type 3. We think that up to 3% of the general population is affected by hypermobile EDS. The genes remain unknown, and it is a heterogeneous group that goes under this label. Classic EDS, in the old diagnostic diagnosis was type 1 and type 2. The prevalence for classic EDS is about 1 in 20,000 due to mutations in COL5A1 and 5A2. And then finally, vascular EDS, the old nomenclature was type 4 EDS. Prevalence is about 1 in 200,000, and most people have it due to a mutation in COL3A1. So we'll use hypermobility EDS because it is the most common as our prototype of the prototype. Again, very common, up to 3% of the general population, and it is defined by the joint hypermobility. And it is common enough that we can find it within even our actors on screen. And so this is lovely Penny, and you can see how she's managing to hyperextend her knee even in heels. So I would like to see her at some point and talk to her about all of her other health concerns. Again, hypermobile EDS is a multisystem disorder, has many symptoms, and then that complicates recognizing the condition. So if hypermobility EDS is defined by the joint hypermobility, how are we going to evaluate that? And we do that with the Beighton joint score. Fifth fingers that go past 90 degrees. It is very important when you do this physical exam finding that the hand is laying flat on a surface so you can actually see the angle of that finger coming back. If your hand is up in the air, you will not be able to determine the right angle. Thumbs that touch the forearms, and this is going forward, not back over the wrist. So going to the volar surface of the forearm. Elbows that extend past 190 degrees. Knees that extend past 190 degrees. And you can see here that the femur and the alignment with the tibia are going past 190 degrees, and especially on the left leg over here. You can also see the tilt in the pelvis and that slope shoulder positioning that people get into when they hyperextend their knees. And then finally, the last point is being able to put your palms on the floor without bending your knees. So you can see the young lady here has increased flexibility at the hips, bends right over and puts the palms flat on the floor. This guy needs a little bit more help and some yoga. He's got some tight hamstrings going on here, but even if we straightened him up, got him to bend at the hip, it's going to be unlikely he's going to get anywhere close to the ground. So in order to be diagnosed with generalized joint hypermobility, if you're before puberty, you need at least 6 points. If you have passed puberty but you're under the age of 5, then you need, or under the age of 50, you need at least 5 points. If you're over the age of 50, you only need 4 points. So points taken is that as we all age, our joints get stiffer and our connective tissue gets a little stiffer. So you need to be more hypermobile as a child than as an adult to meet the diagnostic criteria for generalized joint hypermobility. Clinical caveats to the Beighton score. Children indeed are more flexible than adults, and the Beighton score is only valid if you're over the age of 5. All babies can put their feet above their head, and so we do not typically see children until they're over the age of 5. In general, women are more flexible than men. Indeed, if you look at prepubertal, on average, boys and girls have about 2 joints that will move beyond the normal plane. But after puberty, boys actually lose 1 point on their Beighton score, and women gain 1 point. So just normally. So within the general population, having a Beighton score of 2 to 3 is not outside of the normal. There's also differences in our athletic training programs and differences in sports injuries. Men tend to do more physical things with high contact and high impact, also do a lot more muscle building, which will help stabilize joints. Women tend to do much more of the yoga and stretching. So there's also that difference in trying to take that into consideration. You may need to use some historic information to diagnose adults with joint hypermobility. There is a 5-point questionnaire. If you get at least 2 points, then this suggests generalized joint hypermobility with up to an 85% sensitivity and 95% specificity. So the 5-point questionnaire is, could you now or ever place your hands flat on the floor without bending your knees, or bend your thumb to touch your forearm? As a child, could you do joint tricks or the splits? Have you ever had a shoulder or patella dislocation? And the last, do you consider yourself double jointed? The reason why we need to use this with adults is we may have had more joint injuries, you'll have joint replacements, things that will limit their ability to actually perform a Beighton score on them. These tend to be the most reliable factors on whether or not somebody experienced joint hypermobility in childhood or young adulthood. For obesity, it can make it difficult to assess large joint range of motion. People who have large muscle bulk, it may help decrease your joint mobility. And if you have low muscle bulk, you may have increased joint mobility simply because we need both muscles and tendons stabilizing those joints. For all of us who are working on EPIC and watching webinars on the computer, this goes to our muscular deconditioning. So we all may lose some of that joint stability over time if we're not getting up and moving and engaging our muscles. For sports training, we may increase our joint mobility if we're doing appropriate stretching, and we may decrease our joint mobility if we're working on our muscle strength. For those who have had traumatic injuries that will lead to joint hypermobility and instability, I was in Iowa for 9 years where wrestling was the thing to do. Boys who are hypermobile actually do really well at wrestling, but if you've had a traumatic shoulder dislocation, your shoulder is never the same and you will keep having more mobility and dislocation of that particular joint. Then over time, you may get some early arthritis and then secondarily decrease your mobility in that joint. All right, so how do we assess that joint hypermobility and how does it actually look in the clinic? We will often ask our patients about party tricks. So can you do things like put your feet behind your head? Can you kiss your elbow? Can you stick your tongue up your nose, which is not really a joint problem, but goes to the amount of flexibility in your soft tissue. Can you put your fist in your mouth, which we typically do not encourage people to do, because people will have instability of their TMJ and actually dislocate their jaw and need to go to the emergency room for doing this party trick. Can you put your elbows together? We also ask them things like frequent sprains. Have you had subluxations or dislocations? Are you clumsy or sporty? We've had a few people who describe themselves as clumsy athletes. So that if you're this loose, you may feel more clumsy. You may not participate in sports, but for some sports, it may actually make you excel at that sport. If you need more range of motion out of a shoulder to be a pitcher or to serve at volleyball, definitely for things like wrestling or gymnastics where flexibility is key. But many of our athletes still describe themselves as clumsy. Because your joints are loose, it makes you prone to poor endurance and easy fatigability. And then the poor handwriting. They can induce the swan neck deformities. There's hypermobility of these small joints, which makes holding the pens and pencils more difficult, and early fatigue of the thenar muscles. Along with the joint hypermobility is chronic pain and fatigue. It may be described in childhood as growing pains. In adulthood, may be described as chronic fatigue syndrome. We also see people coming in with diagnoses of fibromyalgia, and it's interesting to note that one of the treatments for fibromyalgia is exercise. One of the newer diagnoses that we pick up is the, quote, chronic Lyme disease. Also of note, it's interesting for this one, people will get on low-dose doxycycline, and remember that at a low dose, doxycycline actually is not an antibiotic, it's an anti-inflammatory. And one of our prescriptions for pain is NSAIDs to be able to decrease that background inflammation and help decrease the amount of pain that people are feeling. So I actually think this is not really a thing, but they're really diagnosing hypermobile EDS inadvertently and treating it with an anti-inflammatory. Our first line of treatment is exercise with a home toning program. So it's not going to physical therapy 3 times a week. It is physical therapy every single day by getting up and moving your body and engaging those muscles to help stabilize the joints. And then scheduled NSAID use for those that are having the chronic pain and fatigue. With the home toning program and the increase in the muscle bulk and the muscle tone, then that engages those joints, makes them more stable, which makes you much more effective at moving, which can then decrease the amount of pain and the amount of fatigue that is being felt. There's also the problem of the negative feedback loop, is when you have chronic pain that you get depression and anxiety. If you are depressed, the studies show that you feel your pain much more intently, thereby making you more depressed and more anxious. So our job is really to try to decrease this negative feedback loop. If we can convince people to get into an exercise program that is slow and steady, that won't hurt them, but encourage them to get up and move and start using their body, they will begin to feel better and then start to move into a positive feedback loop out of the depression and anxiety. Many people I take care of also need to be treated with this with antidepressants or anti-anxiolytics to get them moving in the right direction with that exercise program. From a cardiovascular standpoint, many of our patients will show up in cardiology clinic with autonomic dysregulation, with POTS, with the orthostatic hypotension, but they're also much more likely to have Raynaud's phenomenon and vasovagal symptoms. The old literature shows that about 1/3 of people will have a dilated aorta that usually is observed in childhood to adolescence and is non-progressive. In adulthood, if the aorta is normal, we repeat only if there are symptoms. If there's dilatation, then we repeat the echocardiogram about once every 1 to 3 years per cardiology recommendations. For those women who are pregnant, we do it in every trimester. And then we do obtain an echo for all first-degree relatives. This has become one of the diagnostic criteria for hypermobile EDS. the interesting part is this is an evolving phenotype with other hereditary thoracic aortic aneurysm syndromes. So in my patients where we find a dilated aorta, we actually pause and then do a genetic panel looking at a different subset of genes before we go forward with diagnosing hypermobile EDS. People with all the forms of EDS, but the hypermobile ones also will have this mild hyperextensibility, should be tested on the volar surface of the forearm. The skin may be soft, described as soft or doughy. This is my favorite picture from a very old cartoon where the little kitten is snuggled down in the dog's skin, and she does the little kneading beforehand, and that's what I think of as soft and doughy skin. More prone to having bad stretch marks, prolonged wound healing, wide scars, and for suturing, they may need extra sutures to help the scar hold together or the wound to hold together and to improve that clinical outcome or the cosmetic outcome. More prone to having hernias, and the ever popular easy bruising. So now I'm talking and presenting to people who are in hematology, and no one is impressed by this leg in an active toddler or child, but people will come in and be very concerned about their multiple bumps and bruises. They say they bruise like a peach, and I don't know how it happened. I just wake up with bruises. And so parents who have children with EDS and without will definitely report that their children with EDS bruise more frequently and is more noticeable than their other children. In the head and neck area, we have a higher incidence of myopia, heavy eyelids. Gingival bleeding is very common. Also frequent cavities, difficulty with local anesthesia, delayed onset of anesthesia and resistance to local anesthetics, frequent TMJ pain and headaches, and a higher rate of Chiari-1 malformations. In the abdomen area, we have a lot of functional bowel disorders with chronic functional abdominal pain, chronic constipation, irritable bowel syndrome, reflux, early satiety, and gastroparesis. There's a lot of pelvic pains, heavy periods, round ligament pain, and also an increased risk of uterine prolapse and rectal prolapse. So for the hematologist, you may be the first person to recognize the symptoms of hypermobile EDS. The indications for your clinic are similar to those that are being referred for suspected von Willebrand's disease, the easy bruising, heavy periods, and gingival bleeding. Treatment, we can try some vitamin C, obviously oral contraceptives for the heavy periods, routine dental care, balancing the NSAIDs with hematologic symptoms, and then rarely need more intensive medical therapy. In April of 2017, they came up with formal diagnostic criteria for hypermobile EDS. This is the handout that I made and I use in my clinic. There are 3 criteria. The first is the generalized joint hypermobility, either with a Beighton score or the 5-point questionnaire. Criterion 3 fits down here nicely in the corner, and it's really all the exclusions. Do you have some other reason why you have joint hypermobility? Criteria number 2 needs 2 out of the 3 of A, B, and C, but it's really looking at the systemic features. So systemic features, your family history, and musculoskeletal complaints. So here is the aortic root dilatation, the mitral valve prolapse, why everyone now needs an echocardiogram. When someone meets the criteria for the generalized joint hypermobility, has chronic musculoskeletal pains, but is not quite meeting the systemic features, and in this diagnostic rubric, it's mostly skin and heart, then we give them the diagnosis of joint hypermobility spectrum disorder, or JHSD. We treat this exactly the same way we do as hypermobile EDS, but the hope is that we'll begin to elucidate the genetic etiology of what we're calling hypermobile EDS. But these people with this generalized joint hypermobility the joint hypermobility spectrum disorder, we're going to treat exactly the same way as hypermobile EDS. The two other forms of EDS that are more common than all of the rest are classic EDS, less common than hypermobility, about 1 in 20,000. So for every one classic, you should have 600 hypermobile patients, hypermobile EDS patients. We do know the genes that are called 5A1 and 5A2. They have joint hypermobility. Their joints are very easy to dislocate, but they have significantly less pain than the people with hypermobile EDS. They have true tissue fragility as opposed to the hypermobile form. They have poor and prolonged wound healing, wide atrophic scars, and their sutures will pull out easily. And they have very easy bruising that then leads to secondary scarring. So our children will actually put in shin guards to help protect the shins just from the simple bumps and bruises of childhood. Vascular EDS is even less common at 1 in 200,000. So for every vascular, you should have 10 classics and 6,000 hypermobile EDS patients. The joint hypermobility is variable with vascular EDS, but it's usually much less than what we see with hypermobile or classic. There's a risk of multiple aneurysms, and it's often misdiagnosed as fibromuscular dysplasia. I consider this the fibromyalgia of my vascular land. More prone to arterial and visceral ruptures. It's estimated to be as high as 80% by the age of 40, and your complications increase with age. They have poor and prolonged wound healing and very easy bruising and hematomas. So easy bumps and bruises will end up with huge hematomas and internal bleeding and can be compounded by the internal aneurysms. So here is a listing of the most frequent types of Ehlers-Danlos syndrome. But remember, the most common one that you're going to see in clinic is the hypermobile form. So to review, you may be the first person to recognize the symptoms of a connective tissue disorder, especially hypermobility EDS, hiding amongst your von Willebrand referrals. Hopefully your classic and vascular should come from your geneticist, vascular surgeon, OB-GYN, who has found it first. And then variable findings and other connective tissue disorders, but those also should be coming to you with a diagnosis. Indications are similar to your von Willebrand referrals. And the treatment, hypermobile EDS rarely needs intensive medical therapy. Classic and vascular, we want to avoid trauma and often need more intensive medical therapy like von Willebrand's, especially with surgeries. In classic, we want to put some shin guards on the kids. And again, routine dental care, oral contraceptives, NSAIDs versus your hematologic symptoms and vitamin C. A few resources that are in a handout for you as well. Gene Reviews has overviews of all of these different syndromes, and then the EDNF, Ehlers-Danlos Society, also Marfan and OI are both connective tissue disorders that can have some of these same hematologic and joint problems as well. These are all free access online from April of 2017 about how do you make the diagnosis, what do you do for the different disorders. And my favorite quote from Dr. Charcot from a very long time ago, but applies especially to this group of patients. And I will turn it over back to our presenter.
Terrific. Thank you so much, Dr. Trapane. That was very insightful and useful information. And with that, we'll turn it to Dr. Sarah O'Brien. Dr. O'Brien, next slide. Thank you.
Thank you. Thanks, Pamela. That was a fantastic overview of a really complex group of disorders. And thank you to the Foundation for Women and Girls with Blood Disorders for giving me the opportunity to speak about one of my favorite topics today. So in the next 15 minutes, we're going to talk specifically about the hematologic care for hypermobile patients. Next slide, please. So I thought I'd start off with a very common scenario that we see in our young women's hematology clinic. So this is a 14-year-old gymnast who is referred to hematology due to heavy menstrual bleeding that has been happening since she experienced menarche. During our bleeding history, we learned that she also seems to bruise more easily than her teammates, although she denies any other symptoms of bleeding. We ask about surgical challenges and learn that she has had one knee surgery, and while she doesn't report excessive bleeding with that surgery, she and her mother both start remembering how she did have a lot of complications with wound healing, and she's very unhappy with the way the scar turned out in the end. So now I'm hearing gymnast, I'm hearing heavy menses, and I'm hearing problems with wound healing, and I start to think about a joint hypermobility syndrome. So I'll ask a few more questions, and I find out that she has experienced some joint dislocations, specifically in her shoulder, and that she struggled with chronic ankle pain for the last few years. But both of these have just been attributed to her gymnastics, and family didn't really think much else of it. During the family history, I learned that both the mother and the maternal aunt experienced heavy menses when they were younger, and although they weren't gymnasts, they were both avid dancers at this age. So I purposely did not put Ehlers-Danlos or joint hypermobility on this slide because, as Dr. Trapane pointed out, most of the time our patients will not walk into our office with this diagnosis. Next slide, please. There are several reasons why patients with joint hypermobility disorders could bleed. These include mechanical weakness of the vessel wall, defective subendothelial connective tissue supporting those blood vessels, and finally, defective interactions between platelets, von Willebrand factor, and collagen. Next slide, please. When I'm explaining this to patients and families, I often use the analogy of a steel pipe and a rope. So I talk to them about how their joints are different than mine because their collagen is different. That's why they're more flexible than I am, but that we also have a lot of collagen in our blood vessels. And I ask them to imagine that if you cut or injure a steel pipe, it's pretty easy to put those two pieces back together. Whereas if you cut a rope, it's much harder to put those pieces back together. And I hope that helps them understand why they might be more prone to prolonged bleeding and delayed wound healing. Next slide, please. So for a much more scientifically rigorous review of why patients with Ehlers-Danlos syndrome bleed as compared to my steel pipe and rope, I would highly encourage you to check out this review article, which just came out earlier this year and is a really great review of not only the causes of bleeding, but also an understanding of the new classification that Dr. Trapane went over during her portion of the talk. Next slide, please. There is not a lot in the literature when it comes to bleeding and joint hypermobility, but I wanted to go over a few of the articles that I think are helpful. This first article is making the point that we are going to see these patients in our clinic. So this was a study looking at 55 patients who were already being followed in a bleeding disorder clinic for von Willebrand or platelet function, or in some cases an undefined bleeding tendency. And they compared them to 50 healthy patients with no bleeding symptoms. Next slide, please. So this is an older paper, so it doesn't take account of the new terminology. So bear with me a little bit, but if you look at the second row of this table, it's talking about just joint hypermobility alone. And you can see that that wasn't different between the two populations. And Dr. Trapane pointed out that hypermobility is common, particularly in women. But if you look at some of the other rows that are looking at various ways to define symptomatic joint hypermobility, or what you could probably think of as hypermobile EDS in some cases, there was a much greater preponderance of these patients in the bleeding disorder setting. Next slide, please. What we really need are large population studies of patients with joint hypermobility, getting an idea of the frequency of bleeding symptoms, or the types of bleeding symptoms, and how these compare to the general population. We don't have those yet, but here's what we know so far. This is a small study performed by some of my colleagues at Nationwide Children's, looking at 25 patients with Ehlers-Danlos who were already being followed in the genetics clinic. They had not been seen by hematology. They performed the pediatric bleeding questionnaire with this population and found that a little over half of them did have an abnormal PBQ score. And the most common symptoms were easy bruising, heavy menses, epistaxis, and excessive bleeding after tooth extraction. Next slide, please. These next two studies look particularly at reproductive bleeding. The study on the top was a cohort of 82 patients in Italy with Ehlers-Danlos. The study on the bottom was actually an online survey that was posted by the Ehlers-Danlos National Foundation website. Next slide. These tables show the results of those studies. So the blue table is from the Italian cohort and the purple table is from the much larger online survey. So certainly the questions were not asked the same way in each study, but you can get a sense that reproductive bleeding is common in women with joint hypermobility, particularly dysmenorrhea. Now again, these symptoms are common in the general population as well, so we really need to do studies with control groups. But I would highlight postpartum hemorrhage in the blue table. We know that in the general population, the incidence of postpartum hemorrhage is typically less than 5% in studies. So certainly that number jumps out at me as being different. Next slide, please. And finally, this is a recent study from our own Young Women's Clinic describing 30 of our patients who presented to us with heavy menstrual bleeding and were then found to have joint hypermobility disorders. So I wanted to highlight a few findings. I was surprised to see the significant delay that was occurring between menarche and referral to specialty care for heavy menses. Our mean delay was 36 months, and this ranged from 5 months to 72 months. And again, remember, we're seeing adolescents, so that's a pretty big delay. Also, we do a brief quality of life instrument, the Menorrhagia Impact Questionnaire, for all of our patients that present to our clinic. And there's a question about impact of menses on school activities and another question on impact on sports participation. And we found that in this population, when they presented to us, almost 2/3 of them were having a moderate to severe impact on these activities. And finally, we found that 2/3 of the patients required escalation of their initial therapy, which again, there was not a formal control group, but from my clinical experience, this is higher than most of the patients we see in our clinic. So one of the teaching points from this article is we felt that perhaps joint hypermobility in this setting needs to be considered as a risk factor for a more complex clinical course, and you may want to follow these patients a bit more closely. Next slide, please. I only have one slide on laboratory assays, but it is such a critical issue for these patients because in my opinion, this is the reason why these patients continue to be under-recognized. They present with bleeding symptoms, they undergo a thorough laboratory evaluation, which is normal, and they're sent home and told that they don't have a bleeding disorder. And that's because the hemostasis assays that we traditionally use in our clinical practice are unable to measure the effectiveness of subendothelial collagen's contribution to hemostasis. I did reference a small and a bit dated dermatology paper looking at lab studies, but again, you can see from the numbers that not all patients underwent the same exact test. I would say that I found the 7 out of 37 with the prolonged bleeding time to be interesting. We no longer do bleeding times at my site, but we used to for the first several years that I was there. And I would say from clinical experience, a much higher, almost all of our patients with joint hypermobility had prolonged bleeding times. But again, that's a population that has somehow made their way to a hematology clinic, whereas this would represent a more general population of patients with joint hypermobility. Next slide, please. This is one of the few papers looking at management issues in these patients. And this is from one of my colleagues at Nationwide, Bryce Curlin. And this was, again, back in the days when we used to do bleeding times. And he reported on 19 patients who underwent a desmopressin or DDAVP challenge. The mean bleeding time pre-DDAVP in this population was 11.3 minutes. And for our bleeding time, at least, anything over 8 minutes was abnormal. Post-DDAVP, that mean bleeding time decreased to about 6 minutes. So we found that the majority of patients with Ehlers-Danlos did respond to DDAVP. Today, our practice is still to perform DDAVP challenges in these patients, but I don't perform pre and post laboratory testing. We bring them into the clinic and do education, provide their test dose, watch for side effects, and review fluid restrictions during that visit. Next slide, please. So this is certainly my approach to the hematologic management of these patients, non-evidence-based. So as mentioned, I am a believer of desmopressin for this population. I use it for my patients who have epistaxis. I often like to have it at home. As Dr. Trapane mentioned, many of these patients are talented athletes, and I like to have it at home in the event of injury. I also use it for surgical procedures. If my patient is going to be having a surgery that involves mucous membranes, such as a tonsillectomy or wisdom teeth extraction, I will add antifibrinolytics. For heavy menses, hormonal contraception, yes, absolutely the first line, although some of our patients prefer to use tranexamic acid or DDAVP as alternatives. I think this last question is very important and remains unanswered, and is that, do all patients with joint hypermobility spectrum disorders require hematologic evaluation and management during surgeries? Because we know that not all patients with joint hypermobility have unusual bleeding, but we don't have any way yet to predict who those patients may be. So if a patient has a personal or family history of bleeding, then definitely yes, we need to see them and intervene during their surgery. But if they don't have a history of bleeding, I think it depends. And to be honest, when I get phone calls about this, I almost always say, please make a referral so I can see them in clinic, because I want to take my own detailed bleeding history, family history, surgical challenges, and then make a decision about whether I think some medications would be indicated for this upcoming procedure. Next slide, please. It's also important when we're writing our surgical plans for these patients that we include attention to wound closure, just as Dr. Trapane mentioned. I'm always very careful and polite in my letters. I am not a surgeon, and I make it clear that these decisions are all left to the discretion of the surgical expert. However, I think it's important to make them aware that our patients do require special attention to promote wound closure and healing, and that sometimes closing wounds with minimal tension has been found to be helpful, generous use of deep sutures, and leaving sutures in place longer than the usual duration. And I will prep families with this as well. I'll say, make sure you talk to the surgeon about what the plan is with stitches. Maybe they don't usually do stitches for wisdom teeth, but ask, and maybe they will decide it's indicated for you. So I kind of try to tackle both ends by reminding the surgeon and reminding the family to think about this. Next slide, please. So to wrap up with our patient, given the personal and family history, we do a Beighton score, and we do find that that is elevated at 7. And I almost always actually check a Beighton score when I am seeing a patient for new concerns of bruising and bleeding, even if they're coming in with abnormal PTT or family history of von Willebrand. This patient is found to have mild iron deficiency anemia due to her heavy menses. We do a full laboratory profile. And again, that's because patients can have more than one issue. We definitely take care of patients, and I'm sure you do as well, who have von Willebrand disease and joint hypermobility, or platelet dysfunction and joint hypermobility. I am fortunate in my institution to have a joint hypermobility clinic located within our rheumatology division. So this is the type of patient I would refer there for additional education and evaluation and management of ankle pain. I did want to touch on one point that Dr. Trapane raised regarding the use of NSAIDs in this population. And certainly short courses of NSAIDs are reasonable, but we work with rheumatology, and if a patient is going to need more than a few days of NSAIDs, we usually recommend that they use celecoxib so as not to have negative effects on platelet function. For her heavy menses, we go over the options with the patient, and she decides to proceed with a standard dose estrogen-containing oral contraceptive. We're going to start some iron supplementation, and again, we're going to want to follow her closely. So we'll bring her back in 3 months to assess efficacy and see how she's doing. Next slide, please. So my final point is just that this is a good rule of thumb. And so to look at your patient's thumbs when they are coming to your clinic with new bruising or bleeding concerns. As we've discussed, joint hypermobility is common in these patients, and we're often the first people that may recognize it. And sometimes we recognize it, and then it explains a lot of other problems that the patient has been having before, and it really helps to tie things together for them and improve their overall medical care and quality of life. Thank you for your attention.
Thank you so much to both Dr. O'Brien and Dr. Trapane for the really insightful presentations today. And at this time, we will proceed with the question and answer part of our program. As a reminder, you may submit your questions via the question box found on the right side of your screen in the GoToWebinar control panel. We are getting quite a few questions in, and I know we have limited time. We will stay on the call for a few minutes after 1 p.m. If those of you who do need to go, you may submit your questions, and we will try to respond to those via email if we're not able to answer your questions on the call live today. So do that. Our presenters have been wonderful to agree to that opportunity. So with that, please again submit your questions via the question and answer panel, and I will read them aloud. Let's see. Our first question, is there any data on the tolerability of the Mirena IUD for heavy menstrual bleeding among patients with Ehlers-Danlos, given their predisposition to pelvic pain? Let's see, Dr. O'Brien or Dr. Trapane? Have you seen data, or do you have any anecdotal?
I have not seen data on this question. I can say from clinical experience, we do have patients with Ehlers-Danlos who have successfully undergone IUD placement. The 1 or 2 patients I have personally had that had difficulties with pelvic pain after IUD were patients that were going into the procedure with some concern. So in general, I think patients do quite well.
And I would agree with that because I see the broader group, and not all of the hypermobility patients have easy bruising or bleeding. And we have women all the time who have IUDs. And I would agree, if they have concerns beforehand, then that's usually what predicts who's going to have the concerns afterwards. But IUDs are very well tolerated.
Terrific, thank you. Our next question, could one use the PSA 100 platelet analyzer to evaluate CD-AVP response?
This is Sarah. So I would say no, because for most patients, their platelet function analyzer, or closure time as it's sometimes called, is normal. So we do not use that to do pre and post testing. Honestly, we don't even do that in our platelet function disorder patients during their DDAVP education.
Thank you. Our next question is regarding a patient with von Willebrand disease type 1. Her daughter is asymptomatic, but her grandson was recently diagnosed with hypermobility syndrome. Dr. Trapane, is there a genetic component or is this coincidence?
It could be either. So if we have, the first question should be is whether or not we have true von Willebrands, who diagnosed it and how was that diagnosis made. If it's truly von Willebrands, that is genetic. And then her daughter may not have gotten it, but then it's a grandson. So the grandson also has a father, and so we need to know is either one hypermobile. So you could have two things going on at the same time. I would go back and ask the grandparent how she was actually diagnosed.
Great, thank you. Our next question, from a hematologic standpoint, in your practice, Dr. O'Brien, do you ever recommend limiting sport participation for any of these connective tissue disorders? Actually, either of you. Do you ever recommend limiting sport?
So from my perspective, I use the same recommendations that I do for my other patients with bleeding disorders. So I discourage them from participating in the high contact sports, which is typically football, wrestling, boys lacrosse, hockey, which tend not to be the sports that these patients are drawn to, fortunately.
And I would agree with that, just across the board, anything that is at an impact that is going to dislocate your joints, you shouldn't be doing that. I want you to stay active, but I want you to stay healthy. So lower contact sports, no contact sports are preferable than the high impact. And the more difficult thing is when you make a diagnosis of someone who has been a competitive athlete and trying to remove them from that sport. So trying to gear everybody into more kind, sporty activities to stay healthy.
I find that often a referral to sports medicine can be helpful to help our patients learn what are ways that they can pivot during soccer or do things during gymnastics, et cetera, that will help prevent injury. So how can they be the most successful at their sport while being as protective as possible given their joint hypermobility?
And I agree with that. I love our sports medicine docs that can help people avoid injury, and then also make sure that we are not in some, if we have a joint injury, that we're not continuing to do overuse and continuing to get injury on top of injury.
Great, thank you for that perspective. Our next question is, what are your recommendations for balancing risk for hyponatremia in patients with EDS utilizing desmopressin for bleeding symptoms and the practice of encouraging high hydration and high salt intake to mitigate orthostatic trouble? And then I believe there's a follow-up question he also submits. For example, someone who generally has high fluid and salt intake to avoid POTS, but requiring intervention for heavy menstrual bleeding.
So that's always a challenging conundrum. I think for our patients that have postural orthostatic syndrome, we typically, like that is a patient that we probably would not use desmopressin for epistaxis. If epistaxis is a frequent problem for them, we might be more prone to use antifibrinolytics for that patient. And that's part of what we talk about during when they come in for their DD-AVP education. And so most of my patients are only using desmopressin as we need it around the time of a surgical procedure. But you're right, you definitely want to go right up to the limit of the allowable hydration for those patients and make sure that they're still taking their salt tablets or anything else they may be doing for their pets.
Terrific. Before our next question, we will take 1 to 2 more questions, but I did want to just let folks know that as a reminder, you will be able to download this webinar for your reference on our website at www.fwgbd.org. The link will also be in your follow-up email, and you may access this under the archived webinar section. We will also send you a follow-up email with the information regarding CME. And if you do have questions, please send me a follow-up email. My contact information will be in there. But let's take 1 more question if we could. I know that we're over time, but wanted to get 1 more in there. What dose of vitamin C is recommended, and why is vitamin C a recommendation?
So it's been a while since I've actually prescribed some vitamin C for people, but vitamin C is a component of your collagen modification. So that's why the sailors historically would take lemons and limes on their long distance trips, so that way they wouldn't get scurvy. And so it's a theory that if you give more vitamin C, that it will help stabilize your collagen, whatever is there, and making it work better. Nice that vitamin C is water soluble, so you can't really overdose on it. If your body doesn't need it, you just make really expensive urine.
Terrific. And Dr. O'Brien, did you have another perspective?
No, I don't. I have not used vitamin C for my patients. That's something I learned about today.
Okay, terrific. Let's see. And let's do 1 more question then. How would you treat a woman with both hemophilia A and EDS with a factor 8 level of 30%, but her joints flex often, so she has joint bleeds?
I can't see that one, Kim. Do you mind repeating it?
Yes, I'm sorry. It is.
Oh, I see it now.
Okay. So again, how would you treat a woman with both hemophilia A and EDS with a factor 8 of 30%, and she has joint bleeds?
So I think it would be, you would use the same treatment regimen that you normally would for a patient with factor 8 deficiency, except I think the only difference would be that you're going to probably want to be a little bit more conservative and get the level even higher, because you know she's going to be more at risk for joint bleeds because of her subluxation. And I think the only other thing I would do differently is during times of surgical procedures, you would want to make sure that you're not just giving factor, but also giving an antifibrinolytic, just to kind of account for some of the other more global hemostatic issues that she may be having because of the hypermobility, in addition to the factor 8 deficiency.
Thank you. Terrific. Well, with that, we will conclude our webinar today. Again, please feel free to download this recorded webinar off of our website at www.fwgbd.org under the archived webinar section, and keep an eye out for the email that will be coming your way regarding CME, as well as the resources that both Dr. Trapane and Dr. O'Brien mentioned during today's webinar. This was such a terrific program. Thank you for your excellent questions from our attendees, but also to our terrific faculty for sharing their experience and expertise with us. We are very lucky to have them with us. Thank you all for your attendance, and we look forward to your future participation in our programming.